Gossip.
This is Polyp Gossip, the place for physicians and patients to catch up on what's hot and what's not in CRS with NP or nasal polyp syndrome.
This podcast is developed by Sanofi Regeneron and also elaborated in close collaboration with EUFOREA. Welcome to this 6th episode of Polyp Gossip, which is all about multidisciplinarity of care for patients suffering from chronic rhinosinusitis with nasal polyps or nasal polyp syndrome, and also asthma. We should not forget that the need for multidisciplinarity is very important from both the patient as well as physician perspective, because we are all convinced this will lead to the best possible outcomes of care. To help us in the discussion around this topic in the context of this Polyp Gossip initiative, we are helped by Professor Guy Brusselle, world-leading expert in the field of pulmonology from the University Hospitals in Ghent, Belgium, as well as Professor Wytske Fokkens from the Netherlands, and also Martin Wagenmann from Düsseldorf University in Germany. So, now that we are in the 21st century, having more options to treat our patients with asthma as well as with CRSwNP or nasal polyp syndrome better, there is also the need to discuss more with our colleagues which option would be best for tackling this complex disease. And therefore, I would like to first launch the first question to maybe my colleague here next to myself, Martin Wagenmann. How do you see the multidisciplinarity of care in patients with CRSwNP? And then I will address the same question to Professor Guy Brusselle on the multidisciplinarity of care in asthma. So Martin, you first.
Well, I think there are many aspects to that. Of course, we all agree that multidisciplinarity is extremely important, but what does that mean? I mean, on the one hand, that means that we send our patients to, for example, a pneumologist, but also if they suffer from skin diseases, to dermatology, and that they send patients to us, that we remain in contact. But I think that is only one part of it. We also should ourselves, pneumologists and ENTs and dermatologists, become more multidisciplinary, meaning that we need to understand at least the basics of asthma as ENTs, as well as the pneumologists need to understand some basics about chronic rhinosinusitis with nasal polyps and so on, because that helps a lot.
That's a wonderful statement to start this Polyp Gossip, and I wonder whether Professor Guy Brusselle could complement with his view from the pulmonology perspective on CRSwNP.
I totally agree. It's very important that in each hospital, in each clinic, that respiratory physicians, pulmonologists, and ENT specialists work together, because it's very common that both upper and lower airways are affected in the same patient. And so, as a key message, every adult patient with nasal polyposis should be referred at least once to a respiratory physician to look whether there's concomitant asthma. Often that diagnosis of asthma has not been made, or the patient is unaware of that diagnosis, and we can treat asthma. It's often mild or moderate asthma in patients with nasal polyposis, but we can treat asthma very well according to the GINA guidelines, and so it's important for the patient that that diagnosis is made and that the disease is also treated. Then secondly, every patient with severe asthma should be referred at least once to an ENT specialist, because there could be concomitant nasal polyposis, chronic rhinosinusitis, and so this is very important to recognize because it has also therapeutic implications. And then finally, but maybe this is for the later discussion, we have now 6 biologicals, monoclonal antibodies for the treatment of severe asthma. 3 of them have also the indication of nasal polyposis, maybe in the near future 4 of them. And so it's important that both respiratory physicians and ENT specialists, they consult together and they decide which of these add-on therapies with biologics is the optimal treatment for the individual patient, which is unique.
Well, I couldn't agree more with you. You already give a holistic overview of diagnosis and treatment options in the context of multidisciplinarity, but I would like to have one step back, going back to the diagnosis and the initial stages of disease, where you would recommend, Professor Brusselle, that patients with asthma are all referred at least once in their disease journey to an ENT doctor. But I would like to hear from Professor Fokkens on the basis of what symptoms or on the basis of what signs a patient with asthma presenting to a pulmonologist should be referred to an ENT doctor. So, Wytske, please share your opinion on this topic.
Well, I couldn't agree more with Professor Brusselle, with Guy, about the importance of being seen by both. It's actually very strange that the larynx divides upper and lower airways, like having dermatologist for the legs and another dermatologist for the arms and the back. That would also be very, very strange. So I couldn't agree more. And in special care situations, like in university hospitals where there is an intense collaboration, like in Ghent or Leuven or Amsterdam, where Düsseldorf also, I assume, where we have clinics together, we learn so much from each other that I'm totally happy if my pulmonology colleague decides to treat a patient with nasal steroids, for example, and she's totally happy for us to treat mild asthma patients that are normally treated by GPs via the GINA guidelines. But as soon as it becomes, if that doesn't succeed, if you do not expect what you would expect of that treatment, I fully agree that a consultation of the other the other specialist is needed. If you are not comfortable, if you are not aware of GINA guidelines and have no idea which steps you actually have to take, of course, or the other way around, if you have no idea what the symptoms of the upper airways can be, then of course a consultation is a much easier choice.
Thank you, Wytske. It seems we all agree on the need to have this multidisciplinarity of care, but why do we think this is still not happening in the majority of patients? Why do most patients with asthma remain deprived of a rhinology exam and vice versa? Could you highlight on that, Martin? Why is that? Because our audience may question, why the hell are we not referred to an ENT doctor for a checkup of our upper airways if we have asthma or even COPD? Why is that?
Well, the reason is us four here are working in very specialized centers, and on top of that, we all made asthma or chronic rhinosinusitis one of the focus aspects of our job. In reality, an ENT and even a rhinologist might not always have the option to have a clinic together with a pneumologist in the same room. What happens in daily life is that a pneumologist, maybe if he has the feeling that an ENT should see his or her patient, well, he or she needs to find, or the patient needs to find an appointment, which can be, 2 months in the future or something like that. So we're not in this ideal situation in everyday life. So I think we need to offer some clues to our patients and to our colleagues in our own disciplines and in the disciplines of pneumology and rheumatology and dermatology. What are the typical symptoms? What are signs where, at least in this case, I should send, for example, a patient with asthma, ask him, can you still smell? Ask your asthma patient for smell. That's not difficult. That's, a 10-second question. But if a patient tells you, I can't smell since the last year, that's definitely a clue, an important clue that the patient should be seen by a rhinologist.
Professor Brusselle, what questions can an ENT doctor or a primary care physician or an allergologist ask in order to check whether or not there is the need for referral or the suspicion of asthma in a patient, for instance?
Of course, the classical symptoms of asthma, you all know, it's shortness of breath on exercise, but sometimes also nocturnal awakening due to shortness of breath, a chronic cough, which can also be a nocturnal cough. But then other questions are typical. So respiratory infections, viral infections, which then descend, go down from the upper airways to the lower airways. Patients with asthma will tell this, that often the viral infection goes down. And this is, if this happens repetitively, this is very suggestive for asthma. And then to come back on your previous question, why are respiratory physicians and ENT specialists not working together so closely yet? Maybe it has also an historical perspective, because ENTs are, of course, surgeons. It was originally a surgical discipline, whereas the pulmonologists, respiratory physicians, we are internal medicine specialists. So we have different habitats. I'm a respiratory physician. I'm not feeling well in an operating room, but I feel well in my consultation room. So I love to speak and to talk with my patients. But now, of course, with the new treatments, these treatments, they target specific pathways in immunology, and the immune mechanisms, whether they are active in the upper or lower airways, it doesn't mind. It's the type 2 inflammation, for example, whether this is in the upper and the lower airways, it's the same mechanisms of pathogenesis and the same treatments. So this might unite upper airway ENT specialists and lower airway respiratory physicians. It's, I think, the immunity, the immunology, and the mechanisms of action of the novel treatments.
I think, Guy, all you mentioned here sounds like music in the ears of us here, because we like more collaboration. We also like to be appreciated more by the pulmonologist, and has been in the past. And I kindly invite you to listen to episode 4 of this Polyp Gossip initiative, which is all about to cut or not to cut for patients with CRSwNP, which is all about surgeons talking about medical options. So this is all very exciting and very revolutionary in the field of rhinology, and even more so in the field of CRSwNP. So Wytske, what's your habitat actually? Dealing with the nose as a kind of limited entity, or more looking at the nose and the sinuses in a holistic view, embracing also the opinions of the colleagues from pulmonology?
I'm always so happy that we can cut. There are situations that I'm sure Professor Brusselle would be very willing to be able to cut, you know, just before someone has very, very severe asthma. How wonderful would it be to just open up? But that's something that's not possible. And of course, the other way around, for ENT surgeons, understanding inflammation as the cause of airway problems is crucial. And the time that we could only cut is totally over. And for that reason, I now think teaming up is absolutely necessary. And I personally do not think that it is impossible to have every patient seen once, like Guy said, once by a pulmonologist or an ENT. I think it is a set of mind. And I really think for ENT surgeons, using the SNOT-22 really helps, because that automatically contains questions about asthma. So you're automatically signed that something is wrong in the lower airways too. But I wouldn't even mind, because sometimes it's not so easy to make the diagnosis asthma. So I think we all, from both sides, should just put it in the list, like you make a CT scan before you do surgery. Ask a colleague to think with you. And of course, if it's severe asthma, severe chronic rhinosinusitis, when you consider biological, then it's obvious, then it's absolutely crucial and needed. But even in all those other patients, it's not I think we shouldn't accept it anymore that it doesn't happen.
Well, wonderful. The fact that we are together, talking to each other, coming from different disciplines is already a major challenge and was not happening 10 years ago. So I think this is a major development and a good development for our patients. I just wonder, Martin, about your opinion on when you refer a patient to a pulmonologist and also how you take into account comorbidities like asthma or even COPD when you consider treating a patient with CRSwNP.
No, in general, I completely agree that, you know, every patient with asthma, as well as every patient with chronic rhinosinusitis, should see the other discipline. This is necessary, this is important, and the more we know about each other, I mean, not every asthma is complicated to treat, for example. So more and more we get asked as ENTs, you know, can we modify the asthma treatment? You know, not major decisions, but you know, how often should I take my inhaler, or can I continue to use it on an as needed basis as opposed to regularly, stuff like that, for example. And the same is true for a pneumologist, you know, deciding on intranasal sprays and nasal lavages. I mean, not always do these decisions need to be made by the own discipline. And what has been said about our discipline and you know, not only in this field are medical treatments important. In oncology and ENT, the same thing happens. So we need to learn about immunology. But I would like to mention one other aspect, and we always talked about multidisciplinary teams and stuff. We are ENTs and pneumologists, but in a fair number of patients, this is still not enough. We need allergists. I mean, many of us are allergists and at the same time ENTs and pneumologists. But every so often, we need rheumatologic experience, we need dermatologic experience, sometimes we need experience from gastroenterology. So we need to even broaden our scope here a little bit more.
No, I especially agree with the need to occasionally involve the allergologist and the immunologist in those with immune deficiencies, with those with severe and comorbid allergies and so on. Wytske, do you have a particular comment on that statement?
No, I couldn't agree more. We have a clinic like that with the immunologist, allergologist, pulmonologist, gastroenterologist, and ENT together every other week. And the other week, only the pulmonologist and the ENT. So we sort of and that works fine. And it's fun. I understand what Martin said about, or Guy said about the different habitat, especially the speed of consultation is a big difference. But in the beginning, you know, we are always sort of, come on, let's go. But at the end, you learn a lot. There's a lot of fun, and sometimes it's very nice to have some more time for a patient.
If I can give my own perspective here, in some patients with CRSwNP, we can not only treat the upper airways very well, but they also mentioned that the lower airway part is better under control with the novel treatment options that we have in our armamentarium nowadays. Would you think the same, Guy? If you look at your asthma patient population that have comorbid CRSwNP, are these patients even more satisfied now with the novel biologics that you have available now compared to, for instance, 5 or 10 years ago, where they were left in frustration about the upper airway disease continuing to be uncontrolled?
Yeah, absolutely. There are two aspects to your question. So first of all, if we start a biologic in a patient with severe asthma, if he or she has also concomitant nasal polyposis, that patient will respond even better to the biologic for their asthma. So it's well published in the Blue Journal and other journals that the presence of nasal polyposis in a patient with severe asthma guarantees successful treatment to the currently available biologics. That's one. Second is, as in many countries, also in Belgium, there are reimbursement criteria for these biologics because they are expensive drugs. And so if the patient does not have an obstructive lung function, which is an FV1 below 80% in Belgium, we cannot prescribe a biologic for severe asthma, despite the fact that some of these patients have repetitive asthma attacks and needing oral corticosteroids. So thanks to the presence of nasal polyposis in a subgroup of these patients now can get biologics for the nasal polyps, and the asthma attacks, they disappear. So that's another asset of working together, that we can help the patients according to the official indications, but depending on either the nasal polyp score or the severity of asthma, to help the patient with add-on therapies. And then as a last point, if I may, is I know this is Polyp Gossip, but I will start from my perspective is severe asthma. And so there are many reasons why I love the collaboration with Philippe Gevaert here at Ghent University Hospital. We work already 15 years together. Is severe asthma can be mimicked by other diseases. For example, inducible laryngeal obstruction, which is not asthma. And so no treatment, biological treatment or inhaled treatment, will help these patients if you don't make the diagnosis of an inducible laryngeal obstruction, previously called vocal cord dysfunction. So that's another reason why we need the help of our NT colleagues. And then, of course, the presence of chronic rhinosinusitis with nasal polyposis will make an asthma worse, more severe, more prone to exacerbations. So again, an extra reason to refer the patient with severe asthma at least once to the ENT specialist. So to exclude mimickers of severe asthma, such as inducible laryngeal obstruction, and otherwise to look for nasal polyposis, because this is a comorbid condition which is frequent, which worsens asthma, but also predicts a better response to add-on treatment with biologicals.
It seems, Guy, that you're very excited and very euphoric about these outcomes and novel trends in the field of multidisciplinary approaches of asthma and CRSwNP, which is, of course, wonderful. I suppose Martin is also sharing the excitements. We discussed already about oral steroids, where we would feel more objection in considering them in the context of global airway disease. What is your opinion here?
So it's the global burden of oral corticosteroids which leads to all the side effects and chronic complications such as diabetes and osteopenia and so on. So whether the oral corticosteroids are prescribed or taken for nasal polyposis or for an asthma attack, it does not matter. It adds to the burden of oral corticosteroid toxicity. So we absolutely need to prevent, certainly chronic use of oral corticosteroids for severe asthma should become obsolete. That's really the past. But also repetitive bursts of OCS, of oral corticosteroids, for asthma attacks and or chronic rhinosinusitis with nasal polyposis, this should be limited to 1 or 2 courses in a year maximum. And then if the patient needs more, there should be absolutely a thorough investigation and looking for better and safer solutions.
Wonderful, Guy. I think we agree on the need for better collaboration. We agree on the need for referral to both specialties in the case of suspicion or as a routine part of our practice. I just wonder, Wytske, whether or not we speak the same language when it comes to the ambitions of care. Do we have the same ambitions of care in asthma compared to our ambitions of care in CRSwNP? What's your opinion here, Wytske?
Well, I think we both now, both the upper and lower airways, start to discuss, well, we talked about control, but now we discuss remission and percentage of patients that we can achieve remission in. The first studies, both of the lower and upper airways, are published now showing that remission is possible. And of course, if remission is possible, then the next step we can think of is cure. And we know that for both diseases, some patients have remission without treatment. I always say I have very few 80+ patients with nasal polyps. And the same is true for the lower airways. The number of very severe, very old patients is low. So the disease becomes less. And for allergic asthma, that is very well known. Maybe for late onset asthma, a little bit less. So I'm really thrilled to see what we can learn from spontaneous remission, what we now learn from treated remission, and what we have to do in the coming years to maybe tilt that change in inflammation, what once started somewhere, to change that again to normality. Whether that is possible, we don't know at the moment, but that would really be wonderful.
What you have disclosed here, Wytske, is perfect for Polyp Gossip, because this is kind of off the record. This gives your opinion on the look in the future and how we may envisage on the one hand remission under treatment, and also evaluate the natural course of disease, where some of our patients may achieve remission just by the natural course of disease with fading of inflammation. What's your opinion here, Martin? Because this is very interesting.
I completely agree. I mean, this topic, this interconnection is extremely relevant, and we could even add to that. I mean, one of the reasons that we need more information is that we know so little about the natural cause of the diseases. There are extremely few papers looking at the question, is chronic rhinosinusitis maybe a risk factor for the development of asthma? And if we understood this question more deeply, we could go the next step and think about prevention. Can we prevent the development of asthma by treating chronic rhinosinusitis? I think that would be a very valuable goal.
Do you think the opposite could be possible, Guy? That we could prevent chronic sinus disease if we treat timely for upper or lower airway inflammation? Do you think that's feasible?
It's an interesting question, but I think if you look at the history of occupational airway diseases, often, due to sensitizers, IgE mediated, first occurs the occupational rhinitis, and then months or years later, it's the occupational asthma. So I think that we as respiratory physician, by treating early the asthma, we will not be able to prevent the upper airway disease because it's already present. But it's indeed very important that we should aim beyond asthma control, because asthma control is a snapshot in time and it's mainly focusing on symptoms. We now aim for asthma remission on treatment, so clinical remission, which means no use of oral corticosteroids, no asthma attacks, and of course, no symptoms and stable optimal lung function. And what's interesting is that it's indeed feasible to obtain clinical remission in patients with severe asthma in 1/3 of the patients treated with add-on biologics. And then the risk factors for not obtaining clinical remission in severe asthma are either comorbidities, mainly obesity and depression, but also the longer the disease duration of asthma. And so, due to the fact that the reimbursement criteria for biologics in severe asthma are so strict, we are intervening very lately in the disease course, and we are treating patients who have damage due to long-standing asthma. And it would be much better to intervene earlier when the disease is most active. And we should make the comparison with rheumatology, where, of course, when the rheumatoid arthritis is very active, high disease activity, high inflammation in the joints and in the blood, then we should intervene with biologicals. And this prevents then the damage of the fingers and the hands, and we don't see anymore these severely damaged hands due to long-standing rheumatoid arthritis. And you will not solve that problem of damaged hands by acting very lately in the course of the disease. And I think we need to apply the same approach to airway diseases, where if we can predict which patients are at high risk to develop severe disease, then we have now the means and the drugs to treat them well in an earlier stage of the disease, preventing damage from occurring.
Guy, this is very visionary, and this is indeed to look into the future, and that also guarantees the future of the Polyp Gossip shows, because indeed we have plenty of things to discuss also in the future. But now that you're here as a pulmonologist in this Polyp Gossip initiative, I would like to hear from your side, how important do you think is breathing through the nose in an asthma or COPD patient? How important it is for an asthma or COPD patient to breathe through the nose?
Of course, the nose has important functions. It's to humidify the inspired air, to warm up the cold air outside. And this is important because cold air is an important trigger of bronchial hyperresponsiveness in patients with asthma. So if the nose is blocked and they inspire via the mouth, then this is dry air, cold air, and this will induce symptoms of coughing and shortness of breath in patients with asthma. So it's important in all patients with a blocked nose to help them, but especially in patients with concomitant asthma.
Anything else to add here, Wytske? Because this all sounds like music in our ears, right?
Yeah, absolutely. Yeah, very, very true. No, nothing to add.
Martin?
Perfect.
Music in the nose, I would say, but yes.
Okay, well, time flies, and unfortunately we have to end this very unique and interesting episode. So I thank the audience for having joined us for this 6th episode of Polyp Gossip on the need for multidisciplinarity of care in asthma and CRSwNP. And we invite you to join us for the future initiatives of this successful Polyp Gossip initiative. So thanks to my panelists, Professor Martin Wagenmann, Professor Guy Brusselle, and also Professor Wytske Fokkens for having joined us today. And we look forward to the future of respiratory care. Thank you so much.
Polyp Gossip. This was Polyp Gossip, sponsored by Sanofi Regeneron and developed in close collaboration with EUFOREA.